Hey guys, welcome back to my channel Harrison Learns, where we make internal medicine epic. Today we are going to learn about lung abscess. It is not just pneumonia's evil cousin, it is necrosis and cavitation of lung tissue from infection, often single but can be multiple also. Let's dive in. First off, what is a lung abscess? Picture a pocket of pus in your lung parenchyma, a cavity over 2 cm filled with necrotic gunk. Basically, Harrison's nails it as necrosis and cavitation of lung post infection. Etiology splits into two camps. First one is primary, which is most common one. Basically, there is no underlying lung drama, like there is no pulmonary or systemic condition. Straight up, there is an aspiration of anaerobic bacteria. Secondary, the plot thickens with an underlying villain like cancer, COPD, or immunosuppression. It can be acute or chronic, and it's middle-aged men more common than middle-aged women. Which patients are particular risk for aspiration, such as altered mental status, alcoholism, drug overdose, seizures, or prior cardiovascular or cerebrovascular events. Now let's see about pathogenesis of lung abscess. Basically, it is a bacterial bank robbery in a slow motion. For primary lung abscess, when there is an aspiration of anaerobic bacteria, it leads to inflammation. Then it leads to pneumonitis. When the infection is not clear, then there will be necrosis that leads to cavitation. Boom, abscess. For secondary lung abscess, predisposing factors like obstruction or neutropenia let opportunist crash the party. Let's dive into pathology and microbiology. First one is primary lung abscess. It is most common in dependent segments like posterior upper lobe and superior lower lobe, and right lungs are more commonly affected than left lungs. What is non-specific lung abscess? Basically, they are mixed bugs. What is putrid lung abscess? You will have foul sputum smell. Okay. And in secondary lung abscess, location vary with underlying cause. Pseudomonas aeruginosa is most common organism, whereas Streptococcus specimens is more common in primary lung abscess. What are the clinical manifestations? Basically, patients don't whisper, they roar, like fever, cough, sputum production, and chest pain. Sputum production is often bloody or foul smelling. In physical examination, you can see poor dentition or gingival disease, and you can see amorphous or cavernous breath sounds. They are like wind through a cave sound. And the extra point you have to remember is weight loss and night sweats mimic TB, but this putrid odor in sputum production it alert the abscess. Diagnosis: chest X-ray detects cavities, but CT scan is gold standard because it permits better definition and also yields additional information like spots, complications like empyema. You can do sputum or blood cultures also, and you can do serologic studies for opportunistic infections. You can do bronchoscopy or CT guided needle aspiration, but only in some cases because they have complications. Treatment: always remember, antibiotics are the stars. For primary lung abscess, the first choice is Clindamycin, which covers anaerobes like a boss. Alternative is IV administered beta-lactam or beta-lactamase, followed by, when patient is stable, administer orally amoxicillin with combination of clavulanate. Treatment duration should be minimum 3 to 4 weeks to 14 weeks if it is stubborn. And avoid monotherapy like metronidazole, which misses aerobes. And for secondary lung abscess, always target the pathogen. For example, for Pseudomonas, you can give ceftazidime. If abscess is greater than 6 to 8 cm or there is no response to antibiotics, you can do surgical resection or percutaneous drainage. What are the complications? There will be persistent cystic changes like pneumatocysts or bronchiectasis, empyema or life-threatening hemoptysis. Okay, that's all about the lung abscess. If you have any doubts, please comment. If you like the video, please share it with your friends. Subscribe for more videos. Thank you. Goodbye.